Hi, this is a common scenario. A colleague has asked, it's a 7-hour-old baby delivered by elective LSES at 38 plus 3 weeks. The birth weight of 2.6 kilo, good Apgar score, no maternal risk of sepsis. So the baby has been noted to be mildly tachypnic since birth, and the tachypnea is persisting more than 6 hours. So their admission diagnosis is presumed sepsis and tachypnea for admission. So the baby was pink, mild tachypnea with mild subcostal traction. The chest X-ray shows fluid in the transverse fissure and some perihilar granular opacities. Is it TTN or congenital pneumonia? So just a look at the X-ray itself. So you can see reasonably well-positioned X-ray, and we have the heart shadow, which appears okay. The diaphragm looks normal. The skeleton, slight rotation of the spine. As you can see here, the bending, and the clavicle is slightly lifted, but not significant. And the feeding tube is not seen. So that is one comment. If baby with respiratory distress, especially for non-invasive respiratory support, always have a feeding tube before the X-ray, so that if any issues with the feeding tube position, you can fix it. So as he has mentioned, there is perihilar opacities on both sides, a granular pattern, and there is a fluid-like shadow in the fissure. So the X-ray findings for TTN are non-specific. Hyperinflation usually goes with TTN, but it can go with aspiration pneumonia as well. And as I've explained before, amniotic fluid aspiration can happen in any baby during the delivery process. The labor is a stress for the baby, and the gasping can happen with the amniotic fluid contents aspirated inside. So the fetal lung is filled with fluid, but that fluid is clear. And when the baby is delivering, if there is cord around the neck or cord prolapse or any other concerns, plus delayed labor process, the baby may aspirate, as it happens in meconium aspiration. In meconium aspiration, there is meconium-stained amniotic fluid, and as we know, the bile acid and other chemical components of the meconium incite a chemical inflammatory response, as well as the bile acids have an effect on the pulmonary vasculature, so the increase in risk of PPHN is more. The amniotic fluid has the baby sheds squamous cells, lanugo hair, and all the other components. So it may present just like an aspiration pneumonia, but a milder variant. A slight inflammatory response may happen, and you might see an increase in CRP to say 10s or 20s by the second day. Usually the culture is negative. The baby may need respiratory support for 2-3 days and then starts improving. So the first point in this baby, if the baby has a mild tachypnea with an X-ray picture like this, it's always better to give the high flow or CPAP, not because the baby needs pressure. The tachypnea is because the baby is working more, and the lung might easily close down and result in worsening of the respiratory distress. So make sure you're not just giving nasal oxygen if the saturation is low. Even if the saturation is normal, if the baby has tachypnea and has mild distress with retractions, start high flow or CPAP. I know in the developing countries, cost implications may be there for a circuit, so you may need to monitor the baby. If the baby needs oxygen or if there is worsening, then you go for respiratory support with non-invasive ventilation. Don't give just oxygen in these babies, and always use a blender to give the required amount of oxygen as needed. If you start the pressure, most of these babies may not need oxygen, so just keep that in mind as well. And make sure the humidification is done as well, because non-humidified gas is very cold. It's not comfortable for the baby, and the baby loses energy through the humidification mechanism. And always use humidified source like high flow or CPAP, and the nasal cannula or prongs can be used, or ram cannula can be used if you have the ventilator. I've also mentioned before that between the ram cannula and the nasal prongs for CPAP, there is not a huge difference, except that you may need a higher level of support. So the differentiation of congenital pneumonia, if there is features of infection, like the CRP progresses to rise or the culture comes positive, then you would label it as a congenital pneumonia. Otherwise, it would feature as either TTN or amniotic fluid aspiration or meconium aspiration according to the situation. And of course, if there is antepartum hemorrhage, blood aspiration is a possibility as well, and blood does have components that can cause airway inflammation, similar to what we discussed earlier.